Earlier this year, that's 2024, ARMA, that's the Arthritis and Musculoskeletal Alliance, released its report of the first ever UK national inquiry into musculoskeletal health inequalities. Now, musculoskeletal conditions very broadly mean those affecting bones, joints and muscles, so including arthritis, back pain, rheumatoid arthritis, osteoporosis and so on. Sue Brown, the chief executive of ARMA, spoke to Pain Concern's Miriam Brand-Spencer about the report.
So we wanted to look at what are some of the reasons why there are such big differences in the incidence of musculoskeletal conditions between areas of deprivation and much less deprived areas. So there are very big differences, and there are similar differences when it comes to people with chronic pain. So in the most deprived areas, 41% of people report having chronic pain, and in the least deprived areas, that's just 30%. So those differences, there is no difference between the people living in those areas. There's no genetic reason for this. All of that is related in some way to living in a more deprived area. And that means that all of it is preventable. So what we wanted to look at is what are some of the reasons for these differences, but also what can be done about it. And in particular, what can NHS services do about these differences?
So what were the barriers that you came across?
The first barrier is an awful lot of healthcare professionals and service managers don't really understand some of these social and economic drivers of poor health. And if you don't understand what the issues are, it's very difficult to tackle them. The second big barrier is that there's a real lack of data, and a lot of services were saying we really want to know which of our patients are coming from more deprived or less deprived areas. But it's really hard to do that, because the databases that we're set up with don't include those fields. And you can do it by correlating it to postcode, but you have to extract the postcodes and feed them into a different database and then calculate it back from there. So that's quite a clunky process. But there are also barriers for people who are experiencing musculoskeletal conditions in accessing services. So when services do that exercise of looking where do their patients come from, even though we know that the people in the most deprived areas are the ones with the highest need, you find that actually they're the ones who are not coming forward to the services. And that's because of a whole series of barriers in the way that we set up services, where we put them, how we make people jump through hoops in order to get an appointment. All of that creates barriers. And that's where services can make a massive difference by just looking at what are those barriers for our communities and how can we do something to change that.
So having found these barriers to access and the inequalities that exist, then what are the solutions that you've identified?
So the most important thing is to begin by reaching out to those communities that you've identified are being underserved. And we're coming across more and more people who have done this, and they all come up with different communities. But there's a really good example in the report about they kind of reached out to the community groups that were working in the areas that they'd identified as underserved. So they were really trying to understand who is this, what are the issues for them. And they identified in this case that food insecurity was an issue. So they actually engaged with the food banks in the area. So it's not about going in as healthcare professionals initially. It's about going in and working with the community to work out what some of the issues are. So they were then able to talk to people in the food banks about what the barriers were to them coming forward, and then work out how they could make their services more accessible. So some of the issues that people who are living in poverty have accessing services are things like, where are those services? Can they afford to travel there? Can they afford to take that much time off work if it's a long distance? Can they afford to sit on the phone, holding on, waiting to get to the top of the queue to make the appointment? Do they actually have the data on their phones to access things online? There are lots of barriers like that. And sometimes services are not well placed to deal with that. I mean, one example that we came across was an area that had one pain service, which I'm sure was a very good pain service, but it was a really long way away from the town that actually had the highest incidence of pain. The sensible place to put that service would have been in the town with the highest incidence of pain, because those people couldn't really access it. It's a very long way on the bus and a very long journey, and very difficult. So the physical location of a service can be important. But also, if you're struggling to maybe manage insecure work and put food on the table and pay the bills, the idea that you can make an appointment that might be in a week's time and then turn up at a specific time is very difficult. So people prefer to use either A&E services or NHS walk-in clinics. Those are much more accessible than make an appointment and turn up. So there are a whole range of things that services can do. But the crucial thing is to work out who is that community that is underserved. How can you link with them, with organisations that are already engaging with them, and then find out what the barriers are? Because it won't be food insecurity for everyone. We've also come across services that are not engaged, or find that their local communities that are not engaging might be homeless people, or the Muslim community, or the Afro-Caribbean community, and they will all have different issues about why they're not engaging. So it is really important to do that, engaging with the community and then co-producing what the solutions are.
You spoke a little about some of the positive stories that came out and the good work that was already being done. Can you give me some examples of those?
One of the other examples was around homeless people, and obviously homeless people's access to healthcare is really difficult. But there was a service, a physiotherapy service that, again, they sent, in this case, student physiotherapists into a centre that was providing services for homeless people. So they got involved in supporting the services and working as volunteers within the service. But that way they got to engage with the homeless people who were using the service. They got to talk to them, build trust with them. That was another theme that came out really strongly within the report, about how easy it is for healthcare professionals to lose the trust of people. I think that happens a lot if people don't understand the social situation which people are living in, and therefore their advice and what treatment they suggest may be completely inappropriate. Another example of that was someone talking very much about the importance of the healthcare professionals understanding the community, and that was in relation particularly to rural poverty and people understanding what it means to live not just very isolated from services and very lacking in public transport, but also people who are working on the land, living in a house that is not owned by them but owned by the landowner. So the house and the job go together. It's quite challenging in that case to take a significant amount of time off in order to, say, have an operation because of the nature of their physical work. They're probably going to need longer off work than I might. So it's really that thing of understanding the social circumstances of the person you're talking to and really engaging with them. And I think we talk a lot about biopsychosocial, and healthcare professionals are generally quite good at the bio bit and starting to a bit more to understand the psychological aspects, but really understanding the impact of someone's social circumstances on their health. I think we're a long way behind in that. And one of the things that person highlighted as being important is the more you can employ people who live in the area that the people they're working with live in, the more likely it is that they will find it easier to understand the culture and the social circumstances that their patients are facing. And another thing that came out in terms of the inquiry was the importance of that clinical encounter, the importance of how well you can gain that understanding and that trust of the person you're talking to, and the importance of taking a health coaching approach and of supporting people to manage their own condition. So the NHS talks a lot about self-management, but in a lot of cases, self-management means here's some information and here's a load of advice and a sheet of exercises, go away and do that by yourself. And for people who are living in very challenging social and economic situations, they need a lot more support than that. They've maybe got low health literacy, they've got very little agency and control over their life generally. Just giving them a sheet of exercises is not going to cut it. And having an understanding of what supported self-management means is also really important. We did an oral evidence session on this because it came up so strongly, which is worth a watch. It's really good explanation of what the difference is between self-management and supported self-management and what that support would look like. And that sort of relates to one of the key themes around health inequalities, which is the difference between equality and equity. So if people are facing different challenges, you're not going to get health equalities by treating them all the same. So at the moment we say, here is a health service, you need to self-refer, everybody can self-refer, so that's equality. But if people are facing challenges making that self-referral or attending appointments, what we need to deliver equality of outcomes is equity. And that means treating some people differently for the same condition because of those social, economic, psychological differences.
You mentioned resources on the website. What kind of resources can people find there?
So at the moment, you've got the report, you've got a summary of the report. There will be a series of summaries for different target audiences. And this report also covers all 4 UK nations. So we will be doing summaries that specifically relate to the devolved nations. There will be webinars on different topics. We already have the 4 oral evidence sessions that we recorded up on the website. So that allows you to delve a bit more into the issues around the report generally. There's also the one on supported self-management. There's one on multi-morbidity, so people with multiple conditions.
Yeah, how do you approach someone who has multiple health problems in this situation?
That is a real challenge because everything related to health is focused on single conditions. So all health research will be about single conditions and will probably exclude people who have other conditions that might confuse the results. Services tend to be based around single conditions. All the nice guidelines that exist are all about single conditions. It's a real challenge to work out how can we better integrate services. But it's critically important, particularly for this group. So we heard about people who have, say, 3 different conditions and are seeing 3 different specialists at the same hospital, but are being given appointments on 3 separate days. So if you think about the amount of travel time, travel costs, maybe parking costs, and also days off work that requires. And a concept that came out in that evidence session on multiple conditions was the concept of the burden on a person of managing their own conditions and managing their interactions with health services, and the importance of healthcare professionals thinking, how can I make sure that I reduce that burden of engaging with health services to the minimum possible? Because it is a barrier. And the more conditions you have, the more likely it is that that burden will be too much and you will not be able to manage those conditions as well as you could. And as we have an aging population, we also have a growing number of people with multiple conditions, a lot of which is preventable, but at the moment is not being prevented. And if you live in a more deprived area, you are much more likely to have multiple conditions and develop them at a much earlier age than people in the least deprived areas. So for this particular report, that is a critical issue.
That was Sue Brown of the Arthritis and Musculoskeletal Alliance talking to Pain Concern's Miriam Brand-Spencer. And you can find out more about the Musculoskeletal Health Inequalities and Deprivation Report at ARMA, that's ARMA, arma.uk.net/MSK-health-inequalities-equality.